And this is Dr. Moss, and I wanted to welcome you also, and I want to share with you some of the excitement that we feel with what's going on with kidney supportive care around the country. Yesterday, Dale and I were interviewed by the National Quality Forum. They're doing a playbook on shared decision-making, and they're sort of adding in snapshots, which are examples of implementation of shared decision-making that's according to the guidelines that they're getting ready to release. And they really like what they're doing with the Pathways Project, and they reached out to us and interviewed us that they could include us as an example of what to do well or what to do right. So I wanted to let you know, the National Quality Forum, for those of you who don't know, is a major organization, nonprofit in Washington, D.C. It tries to improve the quality of care. They have measures, quality care measures for palliative care, for end-of-life care, for treatment of a whole host of patients with lots of different conditions. So that's a major good thing. Then a couple of weeks ago, the Pathways Project team met with the quality guru for the Centers for Medicare and Medicaid Services and the head of the Center for Medicare and Medicaid Innovation and described what we were doing. They were very excited. They said they would like to meet with us again. They want us to keep them informed of the progress of our project. That also was very positive. And then the third thing is that we are involved, when I say we, the Coalition for Supportive Care of Kidney Patients, which also includes the leadership of the Pathways Project, is involved in writing a book for Oxford University Press on integrating palliative care into nephrology. And we are now receiving the first draft of the chapters in the book back for review, and the chapters are very strong. And so I'm just getting a very good feel that, you know how we talk about reaching the tipping point, that we are getting closer to the tipping point where maybe we're going to really impact the quality of care for patients with kidney disease. Certainly, there's a lot of sort of national focus now on what we're doing with the Pathways Project, and everybody we describe it to says, well, keep us informed, let us know how it goes. This potentially could be something that the Forum of ESRD Networks picks up and could be part of the work plan going forward in the future for the Forum of ESRD Networks as they look at what the scope of work might be for the various ESRD networks. So I just wanted to share that enthusiasm with you. I'm going to turn it over to Glenda now, who's going to talk about the purpose of these calls.
Hello, everyone. Thank you so much for joining us. Dale, next slide, please. Just a quick overview of what we envision for these calls. We're calling them action calls because they all are about the actions that we're taking now to implement the project and improve care. The purpose of these calls is just like the whole collaborative is all teach, all learn. We're all in here together. There are no wrong questions. We are all here to share, and our expectation is that, therefore, everyone will participate and, of course, will be collaborative and respectful.
So it's Dr. Fuqua. Are you on the line? Or Elizabeth from the DeSoto Dialysis Center on the line?
Yes, sir, I'm here.
Dale, do we need to unmute this?
Yeah, we heard Elizabeth. Yep, we've got Elizabeth.
And it's Dr. Fuqua.
Don't know if we have Dr. Fuqua.
No, Dr. Fuqua. I was wanting to see if you wanted to present the case that's on the slide.
Elizabeth, do you know if Dr. Fuqua is planning to join?
He was planning to join. Let me text him really quickly and see where he is.
So while we're waiting, I just wanted, so the purpose of this is on each of these Pathways action calls, we thought it would be fun to have sort of a mini educational time slot where we would talk about a case that's raising an issue very much relevant to what we're doing with the Pathways Project, which is to try and improve care for dialysis patients who may be seriously ill and may be failing to thrive on dialysis. And how do we, do we negotiate ourselves to palliative dialysis? Do we negotiate ourselves to dialysis withdrawal? Do we continue dialysis and make a hospice referral? We want all of our participating centers to feel very comfortable doing those things if it's appropriate for a particular patient. So, Elizabeth, back to you. Did you find Dr. Fouquet, or do you want to present the case? You have not. Do you want to present this case, or do you want me to?
Go ahead.
Okay. All right. All right. This is a case where we've changed a few of the facts to maintain patient privacy and confidentiality. So it's not a 78-year-old woman, but it is an older woman who has renal disease, hypertension, has had multiple hospitalizations. She's been on peritoneal dialysis for 2 years until her husband became unable to care for her after she had a stroke. She was admitted to a nursing home. The stroke left her with difficulty swallowing and weakness on her left side. The speech therapist at the nursing home placed her on a pureed diet because of her difficulty swallowing. She hates the pureed diet. She's had a number of setbacks, a number of recent hospitalizations, and she told the dialysis staff, "I'm tired, I'm weak, I hate the nursing home food, and I want to stop." And so the dialysis center wisely said, "Well, why don't we get the rest of your family together? Let's discuss this." And so at the meeting, there was the patient's husband and also 2 daughters. The husband and one of the daughters, the daughter who was the medical power of attorney representative, said, "We'll support Mom in your decision." The other daughter violently objected and opposed the decision for Mom to stop dialysis. She said it would be equivalent to committing suicide, and so there was a significant amount of family conflict. Now, in discussing this with Dr. Fouquet, he pointed out one other thing that's not on the slide, which is just last month, there was a new medical problem with those, which is not going to be able to be adequately treated, and really creates this woman now from this other medical problem on top of everything else. She is now terminally ill. So let me stop there and ask, what more would you like to know about this case? So before you make a decision with the patient to stop dialysis, no, stay on the previous slide. What more would you like to know about this case? And Dale, are they all muted, or can people on the phone just speak up?
People need to unmute themselves in order to speak up.
And they hit what to unmute?
There's a little microphone picture, might be at the right of the screen or on the top menu.
So I have a question. This is Mary calling from Westminster, Colorado. You might have mentioned it, or I might have missed it. Did this patient have an advanced care directive?
Perfect. All right. So, Mary, those are just the types of things that we were hoping people were going to ask, because if she had an advanced directive that said, when I get to the condition that I'm in, that I wouldn't want to continue dialysis, that would be very reassuring. And then this chapter in her life narrative would be consistent with what she had previously said. So there was no mention of advanced directives that I was aware of. I was thinking somebody might have said, well, did she for sure have decision-making capacity? She certainly is the one who, my understanding is she did. Elizabeth, correct me if I'm wrong, Elizabeth's from this dialysis center, and I think you're the director of nursing or the unit administrator. I'm sorry, Elizabeth. I don't know exactly which one is your job description. Can you unmute yourself? And did she have decision-making capacity?
She has decision-making capacity, but she did not have an advanced directive.
Okay, good. And was she depressed?
That's something that you and I talked about the night before last, that we have not. According to all of our nurse notes, our social worker notes, I don't see that that's the case, but it is something that we're going to do.
All right. And then I'll ask you, Elizabeth, would you be surprised if she died in the next 6 months? You would not. Okay. And basically, as I told you, she really has this new infection, which amounts to her terminal illness. So the next question then that I'll throw open is, well, how should you respond to this situation? Now we know it's a patient with decision-making capacity, not have advanced directives, who, as best we can tell, nobody at least has said that she's depressed, although you might want to do, I'm about to give you another pearl. They've done extensive research on how to try and figure out how seriously ill patients are depressed. What's the best way to do it, especially a seriously ill patient who is awake and alert and can respond to your questions. And so what the research shows is the best way to find out if a seriously ill patient is depressed is to ask them, are you depressed? You're probably going to laugh at that. A Canadian psychiatrist published a study in the 1980s. His name's Harvey Chochinov, and he did a study on seriously ill cancer patients who were dying, and looking at all sorts of different measures, the Beck Depression Inventory Scale, the Geriatric Depression Scale, the simple question, are you depressed? Are you depressed? Worked just as well, if not better, than any of the other measures. So, Elizabeth, how do you think this patient would respond if you asked her, are you depressed?
I don't know. I mean, I don't know that she would say she's depressed. I know that her lifestyle has changed and she likes to eat good food, so I don't know if that would be. She's not doing that now, so I don't, maybe she might say liking. I'm not sure.
Okay, all right, that's fair enough. And so one of the things, how should you respond? One of the things, if this were a patient in your dialysis center, I don't know, would you want to confirm that she has decision-making capacity and talk to her about advanced directives and medical orders? Certainly, if she's going to stop dialysis, you should put in place a do not resuscitate order and probably a do not intubate order, and probably a do not send to the ICU order, because if somebody's stopping dialysis and they're a long-term dialysis patient, we know within a week, 2 weeks, they're going to die from their uremia, and that's an expected outcome. And so certainly you don't want to be doing CPR, which is very traumatic and would not be effective in somebody who's dying from uremia. So the point is, if this were a patient in your unit, you'd want to make sure she has decision-making capacity. You want to make sure that she's not depressed. You'd want to get the family together just to talk it through. Now, all things being equal, if this woman says, no, I'm not depressed, this is hypothetical, no, I'm not depressed, I'm just not satisfied with my quality of life. It's not that I want to die, it's just that I don't want to keep living the way I'm living. And so she pretty much seemed to be clear mentally, understood what was going on. She was very dissatisfied with the quality of life. Then the next issue you need to deal with is her daughter, her youngest daughter. And then you need to explain to her that years ago, ethicists looked at this, and there's a difference between suicide and stopping a life-sustaining treatment. And this patient, when she stops dialysis, is dying from kidney failure, not dying from any medicine that she ingested or anything of that nature. So that stopping dialysis is not the same as committing suicide. And then the second thing you would explain to the younger daughter is your mom ethically and legally has the right to make this decision, although you may not be in agreement with the decision she's making. This is her decision to make, and you love her much and you hate to lose her, but this is what she's chosen to do, and we need to legally respect her wishes. So that's the way, and we could spend much more time talking about this. We need to move on, but was this worthwhile to just sort of go through a case like this and talk about it? Yes, no?
Yes, this is Mary from Westminster again. I think it's really valuable to have these kinds of discussions because it's complicated, and some of the ideas that you brought up, I think, were helpful in guiding the social workers, or guiding us in having these conversations, these difficult conversations.
Okay. Well, why don't we move on, Dale? So I want to just give you a pearl, which is something that's small but of value, and hopefully on the next slide, we're going to just talk about the shared decision-making process that we taught you in Washington, D.C. Looks
For
like.
some reason, I'm having trouble moving the slide. Hold on, I'm working on it.
Okay. All right. Well, I'll just talk to you about it. So the next slide is about shared decision-making. And what you learned in Learning Session 1 is the process of shared decision-making. You learned how to sit down and talk to patients and find out about their values, preferences, and goals. And one of the chapters that's been written for this new book I was telling you about, the three authors, Ernest Mendel, who's a nephrologist at Harvard, Jane Schell, who's a nephrologist and palliative care physician at the University of Pittsburgh, and Rob Cohen, who's a nephrologist and palliative care physician, I think at Beth Israel Hospital in Boston, one of the Harvard-affiliated hospitals, identified that in shared decision-making, there are six common elements, and whether you're talking respecting choices or whether you're talking Vital Talk, and what you learned was Vital Talk in Washington, D.C. Whichever one of those that you learned, and in this case you learned Vital Talk, that they have common elements. And I was unfortunately, I'm not on my usual computer. My monitor screen went black 15 minutes before this webinar, so it looks like Dell is trying to get us back on. You can give. Well, that's the question. Can you get us to the next slide? There we are. Okay, so these are the common elements, whether you're looking at Respecting Choices, Vital Talk, Serious Illness Conversation Guide, or SPIRES, which is a variation of SPIKES, Setting Perception, an invitation to give information, then you share the information, which is knowledge. E is you respond to emotion, and then S is summary. And so if you can see these 6 skills here, is it all right if we have this conversation today so that we can know what's important to you? You identify what is their understanding of the patient's current illness, or if the patient lacks decision-making capacity, what does the family understand about what's going on with the patient? What's most important to the patient? What are the patient's values, preferences, and goals? For anything in which maybe the family has not indicated that they have a complete understanding, or the patient has indicated that, you would share additional information. Then if they get upset because they said, oh, I didn't realize that her kidney disease was that bad, or I didn't realize that her heart was that bad, you respond to the emotional cues. And then once, you've sort of allowed them a little bit of time to sort of regroup and say, okay, let's go on, then you make a recommendation that's based on what you've learned about the patient's values and what's appropriate for the patient's clinical condition. If I can have the next slide. So why are we doing this? We're doing this, go back one, because shared decision-making, the research shows, is very important. It improves or enhances the patient and family's understanding of the patient's condition and prognosis, enables decisions to be made based on a common understanding of what's important to the patient and the family. It strengthens the patient-family-physician relationship, or we could say clinician relationship, or the relationship between patient and family and all the staff at the dialysis center. And it improves satisfaction with the decision-making process. And I don't know if you know, but there was a New England Journal of Medicine article that said that shared decision-making is the pinnacle or the very height of patient-centered care. And, of course, when we were all together, we talked about how patient-centered care is one of the top priority values or qualities that, that are supposed to be in the practice of medicine in the 21st century. So I just wanted to give you that encouragement that what we're doing is really part of what's acknowledged to be the way healthcare should be delivered. And in fact, I just told you yesterday that we were talking to the National Quality Forum because they see what we're doing as very much in line with this information I just shared with you. Next slide.
Well, hi, this is Glenda again. For those of you who have joined since we started, welcome. This is just going to be a quick review of, remember that we are in action period 1 now, which is the time between our learning session 1 that we had last month and our meeting that we will have in October. And so during this period of time, action period 1, you left us with a number of key activities, and I'll just give you a little reminder that in your binder from the meeting, the very last tab, it was called Action Period 1, and it has a 3-page document there. that goes over in a lot more detail than this. And so if you haven't looked at that since you left, and I've talked to several of you about that, I recommend that you pull that out, have a look at it, see where you are in this process, and just quickly we'll review the overview here of distributing and returning the KSCIC surveys. We had said by April the 30th, and we've had a great response out of some facilities and less out of others. And so we have decided to leave this open for another couple of weeks. And so if you haven't yet had an opportunity to ask all of your staff and nephrologists to complete the survey, please do so. Make a new push now in these next couple of weeks. It may be easier to give them a hard copy survey than to ask them to go online, but either way, those options are available. You were to come back and organize your change team and to inform your colleagues about the project and to conduct a death review of at least 5 deaths and see what you could learn from that. Clearly, you have the activity of the identifying seriously ill patients, and we asked you to go back and identify all your seriously ill patients by May the 1st. Remember, and you submit those names to the Pathways team and whether or not they can be interviewed. We are in the process of, and we have a Spanish translation for the patient materials that, Dale, I believe, are still in need of IRB approval, but we'll be getting those out fairly quickly, we think.
Correct.
Yeah, okay. In just a reminder that you identify your seriously ill patients, you move on to your goals of care. Remember to do the online prognostication for your seriously ill patients before you enter into your goals of care conversation. That's what's recommended. And you will have now be thinking about how you're going to extend the Vital Talk training that you got to other staff and be planning that as a team. Remember that Dr. Moss is available for clinician's dinner or for individualized consulting, as well as I am available and will be talking with each of you at least on a monthly basis, if not more frequently. When you get ready to conduct your goals of care conversations, which I think you're moving towards now, who leads that? Who's going to arrange the meetings? How do you follow up with your shared decision-making and plan of care and address the EMR issues? And again, remembering to do the online prognostication. So that's just a quick overview of that. I think we'll go to the next slide. And we're going to have some check-ins. Remember, we said that this is an all teach, all learn, and we would love to have participation from everyone. We're all here to learn together. So I was just going to ask a couple of people. We have want to check in about what you've learned since you went home. And one of the first activities was conducting the death review. And I would like to ask Steve from Atlantic to share with us a little bit about what they learned in doing theirs. Steve, are you there? I saw you join.
Yes, can you hear me?
Yes, we can hear you.
Perfect. So yeah, we all of the facilities were able to get me their mortality reviews. We actually have 3 clinics participating, so we were able to get 15 patients reviewed. We found out that pretty much things were kind of as we expected, which wasn't all that great, but we do have some successes. Just to kind of run down, give folks an idea of our baseline. About 2/3 of our patients have a death that's expected based on this small sample size. One of the things that was encouraging for us and a little surprising was that we had 100% of our patients of these 15 that completed an advance directive prior to passing away. And we're hypothesizing that that has to do with the fact that all three of these clinics are involved in an ESCO. And whenever we roll out our ESCO initiatives, we roll it out for all patients, not just the ESCO patients. And one of the requirements for ESCO is to have advanced care planning conversations or at least paperwork. So I think that's why we are there. The question of whether that actually translates into conversation was answered a little bit later on the survey. Did the physician or staff document discussion of advanced care plan and what matters most to the patient? And that was only 47%. So yes, we are getting the papers in the chart, but now our next battle is to actually talk about those papers and see what they actually mean. We had approximately, again, 2/3 of our patients that had a surrogate named as a decision maker, so that's definitely an opportunity for improvement for us. We found, I think, consistent with what we expected, that most of our patients die from either heart disease or cancer. That's pretty in line with what we were expecting. As far as having other orders limiting medical intervention, we only had 13% of our patients that had a DNR. That also was not a surprise to us. We have historically not done well with collecting those types of documents or having those conversations. Location of death, about 60% of our patients died in the hospital. 20% died at home, which I was actually surprised that that was so high. And 13% died in the nursing home. 80% of our patients were seen in the emergency room in the last month of life, which is in line, I believe, with what we've learned from the literature, and definitely something that we would like to work on. Only 50% of our patients were comfortable in the last week of life, which is absolutely something that we are going to be targeting moving forward. And was the patient treatment consistent with the patient's wishes or goals? We were only at about 2/3 there. And I think part of that is driven by, we had several patients where it was unknown if the patient's treatment was consistent with their goals, probably because of that 50% statistics where we just hadn't chatted with them about what their wishes were ahead of time. So I think that's what you were looking for, Glenda?
It is. It's very helpful. I think you also identified about the bereavement that you're going to
yes.
work on that, right?
Yep.
So,
only 15% of our patients did our care plan address the family bereavement concerns, which was basically 2 patients. So that's definitely an area where we need to improve. We need to not drop our families just because the patient has passed away.
Okay. Well, thank you so much, Steve. We also have Devin with ARA Colorado, who's going to share some of their learnings from their death reviews there. Devin, are you on?
You're very, very faint.
What about?
We're not hearing you yet.
Sorry, Devin, we're not able to hear you.
Try again. You're very faint. Can you get closer? Yeah, that's a little better. Can you get closer?
A little better. Can you hear me now?
Yes, that's a little better.
A little better? Okay.
Oh, yeah. Okay. Thank you.
Better? Okay. Sorry about that. Yeah, so I think we're looking at 5 here. This is Devin from Area Westminster in Colorado. Mary did 5 chart death reviews for us, so thank you, Mary, for doing that. I think our results were pretty consistent with Steve's there. The stuff I think we saw that we liked were that we had 3 out of 5 referred to hospice and on hospice at the time of death, and we had 4 out of 5 died at home, and 4 out of 5 were expected deaths. So I think that was all good stuff to take away. I think the real value in this, though, was seeing how consistent we were when we were off. And so we were pretty bad at advanced care planning we had 0 out of 5 that had a living will or a surrogate decision maker. Fortunately, 4 out of 5 were their own decision makers, but 1 out of 5, one of our patients was well known with dementia and declining cognitive function, and we were kind of operating on autopilot. His wife was the decision maker, but that had never been documented, and so we were making all those decisions. And it was actually a case where he probably would have benefited from a living will, which had never been in place, because she continued dialysis for a long time after I think most of the IDT, the interdisciplinary team, thought that it was beneficial to the patient. And if there had been a living will in place when he was able to make these decisions for himself, that could have really been beneficial. I think that really highlighted that area of need for us pretty significantly. So that was like really valuable to see that. And so
Excuse me just a minute. If you are not speaking, would you, not to you, Devin, but just to everyone, we're getting a lot of background noise. If you're not speaking, please mute your phone. Thank you. Continue, Devin.
Okay. And so kind of looking at that, we're brainstorming on how to fix that. And I think one of the ways, two very small changes that I think are going to help us a lot that we're going to start implementing are going to be, we're going to start screening for decisional-making capacity on admission. So when patients are getting referred to us and they're still in the hospital, we're going to add that small bit of information. Is this patient a decision maker right at the admission, when the admission starts? That way we kind of know we're on it before they're even in the clinic. And so, that'll kind of keep it on our radar instead of like letting it fall into the background, so we don't end up in a situation where we're really just operating on autopilot again. And then the other thing we're going to be looking at is in our monthly PCC meetings with the physician, we're going to ask, do we want this patient's decisional-making capacity evaluated? And we're going to be more upfront about that, or more aggressive about that, so they don't decline too rapidly, and then by the time we actually get to it, they're unable to make decisions. So we're going to be looking probably at referring to the PCP for that. I believe we're hoping to kind of already start making some changes from what we found.
Thank you so much, Devin. And Steve, and so I'd just like to, could you go back, Dale, please?
Yeah, I didn't.
Okay, thanks. So I'd just like to open it up for others that are on the call to share. Are there other things that you learned from your death review that you would like to share? And or Woody, if you have any comments about what you've heard? Woody or Dale?
Yeah, I'm here, and I think what I heard was great, that, you're identifying the areas where you're doing things well, but you're also identifying areas where maybe you could do things a little better. We do have a handout on how to assess decision-making capacity. I think we may have made it available, but maybe, Sherry, after the call, you could email it out to everybody, just so that, because really assessment of decision-making capacity is something that the team can do if they're comfortable doing it. If not, often people get psychiatry consults to assist with that assessment. But sometimes it's pretty clear. If the patient doesn't understand what's wrong with him or her, and obviously doesn't have the memory and understanding to even participate in the decision, then you know that they lack capacity. So I just think the results from the death review are great.
Okay, great.
And one comment from me. This is Dale. Just the observation that you made that the wife stayed with dialysis for a long time. One of the rationales to give to family members to the patient for why they might want to do an advance directive is that it really relieves their decision maker of a great deal of guilt and burden if the decision maker is clear that they're following the patient's wishes. But if they don't really understand that that's the patient wishes, then they can feel a tremendous amount of angst and concern. Like in the family meeting we discussed in the case, where one patient was, quite concerned about. One family member, one daughter was quite concerned about it. But a patient who makes that clear ahead of time, this is what I would want, makes it much easier for the family. And patients often appreciate being reminded you are saving your family members from burden and guilt and angst.
Great, thank you. All right, well, let's talk a little bit about some successes. I want to open it up. We've got a couple people that we're going to ask to share some things, but let me just open it up first and see if there's someone who has a success that they'd like to share with everyone. We'd love to hear about it. Well, okay, be thinking and don't be shy to get on and tell us about it so we can celebrate with you. Dr. Sanchez or Mary Beth, are you on the line?
Can you hear me? This is Mary Beth.
Hi, Mary Beth.
Hi.
Well, we had learned about and asked the DNA Dallas CKD clinic, so Mary Beth Callahan is on now to talk about what they learned when they started doing some work around the surprise question with nephrologists.
Well, we've learned a few things. The surprise question we haven't approached with the nephrologist yet. There's still a little delay on getting full approval, as Dale probably knows. But what we did learn, which we think will just work smoothly into this, is that the office where we are trying to focus the Pathways project is also doing another pilot project on chronic care management with an arm of it referring out to the supportive care team. So that's a positive. I will say that in a large practice, I don't know about y'all, but in a large practice where there's maybe 3,000 chronic kidney disease patients in one office, what we have found is that maybe no one knows when the patient dies. And so there's a lot of room for improvement here, I would say. So we had a meeting yesterday with some of the administration, and we're meeting with the doctor group there on Wednesday to go over the KSCIQ and the surprise question that we'll be asking of them to do on some of the patients. So that's where I'd say we are.
Okay, thank you, Mary Beth. I think I remember when we talked that that Catalina had been working with a couple of new physicians that she was training, I believe, and she talked to them about the surprise question, and they had never heard about it.
That's right. We are ongoing training. We've got about 17 of the 99 doctors trained in the serious illness conversation. But last week, 2 nephrologists had not heard of it. So I think we're making progress, and there were a lot of aha moments in the training. So what we're hoping is that at the Landry office, where we're hoping to implement this, is that all of those doctors get trained in conversation, goals of conversation. Probably SICP is what we'll use. So that's our goal.
Okay. Well, thank you for sharing.
Thank you for your
Yeah. Steve, are you still with us? Would you just talk a little bit about your setting up your processes for the monthly surprise question?
Sure. So 2 things. As far as process goes for the monthly surprise, what I've done is the unit gets 2 days assigned where they screen all of the patients over the course of those 2 days. This way I can make sure I get my data back, and they have a very discrete period of time where they can just kind of take care of it and get that information in. It's usually I think the surprise questionnaire is due the first of every month, so it's the 2 days prior to that day. And then there's one person on the team who's responsible for sending that file over to me. We actually had some concerns about our physicians being able to handle the volume of screening. So we turned that over to our nurses, and then there was some concern that is it really valid for the nurses to do the surprise questionnaire, because much of the validations regarding physician, Dr. Moss has given us a paper that does describe that nurses can do the questionnaire and it is valid with them. But we've done our own little internal numbers, and we are finding that there is about 80% concordance between the nurses and the physician or a nurse practitioner when they screen the patients. There's only about 20% of the time that they don't agree on the same rating. Of that 20% of the time that they don't agree on the same rating, it's split almost exactly evenly, whether the nurse says that the patient's doing worse than the physician does, or the physician says that the patient's doing worse than the nurse does. So we're fairly confident. That's 206 patients that we've used. We're going to do it again this month with both the nurse and the practitioner. That'll bring us up to about 410 patients or so. And if the information continues to look like that, we'll be fairly confident that we can move forward with just the nurses doing the surprise questionnaire to streamline our process.
Right, and I know that, Woody, you want to comment there?
Yeah. So that's really good. And so experienced dialysis nurses are better than dialysis nurses who just graduated from nursing school. And really 80% agreement between your nephrologist and your nurse is great. We did the study here with experienced nephrology nurse practitioners and experienced nephrologists. Our agreement was 85%. So it's never going to be 100%. And I think 80 or 85% is great. And that's certainly good enough. And I saw some data. What percentage of your patients were screened as no, I would not be surprised?
So cumulatively, again, just that 206 patient carve out, we were at 23%.
I think you said 23. Yeah, 23%.
Yep, 23%.
23%, which is right on the money, because when people have done this research in multiple different dialysis centers in different parts of the country, invariably it's somewhere between 15% and 25%. So for this project, we've estimated probably be about 20% of every dialysis center's patients. So Atlantic, you seem to be doing this process very well.
Thanks.
Steve, this is Dale. I do have one question about it. So once the patient is identified as surprise question no, in other words, positive for being seriously ill, are you recording that somewhere, or is there something that the nephrologist is then made aware that you've screened the patient that way? Because if screening them, it triggers a little bell for them. If they're not screening it, are they getting that little trigger?
So that's our next phase starting this month. We're going to do the questionnaire for June. Once we have the results back, anyone who screens positive, we will obviously do the online tool to further reinforce that, and then the team will be responsible for either speaking with the attending nephrologist. If the attending nephrologist wants to handle the patient and doesn't want us involved, because we've set ourselves up as a consult service, then we will document that conversation, and we'll document that the attending nephrologist has opted to move forward on their own, or the team will schedule a meeting with the patient and move forward with that appropriate documentation. So either way, the physician would be notified, and we'll get that into the EMR.
Great, thank you.
Right. And just to make the point, Steve, and the patients that you're identifying as you wouldn't be surprised, so asking them if it would be all right if they participate in it. Is that correct?
So yeah, we've enlisted we have data curators for our ESCO program. They're used to collecting the data for advanced care planning and all that, because that's part of the ESCO. So we've enlisted them to fill out the research component of that, and also to have the discussion with the patient regarding whether the patient would be comfortable with being contacted. This way we can kind of separate the clinicians and the research component a little bit.
Okay. All right. Very nice.
Okay. Thank you, Steve.
You're welcome.
And Mary Beth. So now, what about challenges? We've talked about learning some stuff. We've talked about some successes. What about challenges? When we went into the project, we all met together. We had what we call the World Cafe roundabout that we did, and we collected your thoughts about what your concerns were, how you thought you would be challenged. Some of those results where there was a lot of agreement between everyone is the challenge of time, and I've already heard that come up once already today. How do we have time to do this? We're still doing all of our other work, and everyone is very busy. So time, if you are challenged with that and you're trying to find a workaround, would you share with us about that? Another concern was in family disagreement, which we saw in the case that we've already discussed today. So how are your attitudes and values going? What about the challenge of getting other staff members trained in the project, just the awareness of it? Anything to share with that, anyone? Let me open it up. Well, okay. Dr. Essen, are you on the phone? Well, how about Mary? Mary?
Yes.
Okay. Would you just talk and share with everyone about the concerns that you all identified, the challenge that you identified about getting buy-in from the nephrologist, and what kind of a plan you all have made about that?
Well, I think Steve did a very nice job of talking about the challenge with and Mary Beth for that matter, communicating with the physicians and their paradigm about talking to patients who have serious illness or who we answer no to the surprise question. And that's not different here in Colorado. So, but in thinking about that, what we thought we might do is one of two things, or both for that matter, have a call with our nephrologists and nurse practitioners, maybe a video conference with Dr. Moss, just to share his point of view and perspective, sort of bring an outside person in to have that conversation with our staff, our medical staff. And then secondly, we're thinking about and sort of reaching out to the University Hospital here, as well as the VA Hospital palliative care teams, and doing something similar, bringing them in to meet with or speak with our nephrology team and just have this ongoing conversation about having conversations like this serious illness conversation.
That's great. Thank you so much. Is anyone else dealing with the challenge of getting physician buy-in and comfort level with moving forward, talking about palliative supportive care with patients?
We have this is Mary Beth. We have varying degrees of trauma and buy-in.
Yeah. Okay. Huh. How about anybody else? Go ahead.
Well, the other thing that, of course, is probably a little different for us, but the other thing is that after they become a little comfortable with it, if they don't use it within the first 2 weeks, we're finding that, they're not going to use it for a while. And yet having office hours to discuss some cases and stuff.
That's a really good point. It's like all of us as adults, when we learn something, we need to practice it to retain it and or to get proficient at it.
Right, and to feel comfort.
Okay. Right. Okay, anyone else? Rogerson, we haven't heard anything from you. Is there anyone on the call from Rogerson that wants to share something about, I know that you all have had a little bit of a challenge waiting for your IRB approval, but I know you've done some work identifying the seriously ill patients.
Hi, it's Barbara Casazza at Rogerson, Queens.
Hi, Barbara.
Hi. We've gone through and identified our patients, and we're setting up a meeting with our team now to get things moving. Because, yeah, as you said, we were a little bit behind the 8 ball. So we've got a meeting set up with the nurses and the social workers who are on our team, and we'll get the ball rolling on that and go through and talk to the patients about who seems to want to take part.
Great. And what percentage were identified? I'm curious how how surprise question.
About 10%.
About 10%. Okay. So at the lower end. Okay.
Okay.
All right. Well, we are coming up to the end of the call. I want to just open it up to anyone that's on the call that has something to share with us or questions that you may have.
I just wanted to comment very quickly. I'm actually at the CMO meeting right now, and we just had a presentation before lunch by Northwest Kidney Center, Suzanne Watman, and they're doing some really, really great work on palliative care. They have a palliative care team. So if anyone's looking for someone to contact, or I don't know if you folks at GW are aware of them, but her presentation was very impressive. So.
Yeah, we had recruited them hard to come in and be part of the project, but they felt that they needed to do their own. They had their own process, and they needed to do that as part of Pathways. But perhaps, do you think they would make a good faculty on one of these calls?
Absolutely. I think they're a great resource. I think that they really have the same ideals. I think they're on the same page, and I think they've had some really good successes. So, yeah.
Okay, great.
Okay, thanks, Dave. Well, could we just go to the next slide, Dale, please? Okay, so call to action. Remember, we're in action period 1, and we're on an action call. So I'm wondering if anyone has anything to share about what your next steps are, what you're hoping to accomplish before our June action call. What is it that you need to have to accomplish that? So we want to send you out in action. I will just review a few things that you want to be thinking about, and that is, to get your death review done if that is not done. Talking about your team formation and education and how you're going about, I've mentioned this several times, educating other members of your change team and to share the knowledge of the whole project with all of your team. We've talked about buy-in from physicians. You're going to be coming up to be doing the seriously ill audit. And, of course, your first monthly data collection and reporting is coming up on June the 5th. And you will be, now that you've identified all of your seriously ill patients, then you will be needing a process by which you'll do that on an ongoing basis, including the seriously ill prognostication. Anything that anybody wants to share about what they see as their next steps or questions about that?
Hi, this is Sonika Pandey. I'm calling from Washington, D.C. VA Medical Center. One of the
hello.
Hi, I'm one of the palliative care physicians here at the VA, and I'm collaborating with the renal team here. We have very good collaboration to start with. We're working through IRB process right now. We started a little bit late, so we are in the process of paperwork and hoping to complete it soon and hopefully get start from there. We already talked about the team formation. We already presented the project to different members of palliative care team. Renal team is involved. We are doing weekly meetings just to see and make sure the project is going forward, and we are just pushing ourselves to do that. So that's where we are. Just wanted to say hello to everyone, and looking forward to
thank
continue
you.
with the group.
Thank you for sharing.
Thank you, Samantha.
Anyone else like to share anything with us about where you are, what your next steps are? Dale, Woody, would you like to make some kind of closing comments? I think we have about 3 minutes left. We have a final slide, I believe, with some information, some reminders. You got your newsletter, I believe. Have you seen that? We're going to have a goal of getting one out on a monthly basis or thereabouts that contains information and resources. We have our listserv, which has been rolled out, the box where all of the documents and resources are stored. So those are just some reminders. Dale, Woody, I'll turn it over to you.
Dale, do you want to go ahead?
I had to unmute myself. Yes, well, thank you. I know a couple sites we're still working on IRB pieces, as Sonica said, for VA and for Dallas Nephrology. So thank you, everyone, for your patience as we work through the cross-organizational pieces there. I thought I appreciated hearing of progress, and I hope that as we do these calls, send us ideas of what you'd like to hear about. Glenda's going to be talking with each of you monthly at least, but feel free to just send us an email like, if you'd really like to have a faculty member about this, or you've got a good case you want to discuss. So these calls really are for you.
Right. And then, Dale, if I could also tell them that we would love to have a case for each one of these calls.
Yeah.
And so if somebody has a case, why don't you send me an email or call me. I did send out contact information. If you need it again, send an email to Sherry, and we'll get in touch with you. But I can help you pull the case together for presentations. And thank you to ARA DeSoto for the case this time.
Yes, thank you. You were brave to be the ones who led off. We really appreciate it, and it was a case that picked up on so many of the themes that had been discussed in the World Cafe: the family conflict, the need to pull the whole team into advanced care planning. It was really helpful. Thank you. Thank you, everyone. We appreciate the hour. We know it's a chunk of time, and we appreciate all of the enthusiasm, all the work you're doing to make these changes.
Right. And the thing we want to do is make sure this is worthwhile for you, so it's an enriching experience. So please give us feedback, send us emails.
Great. Thank you so much.